Okay, are we live now?
Should still be.
Okay, we've tried several fixes and the technology this morning here is not working. So we can't conduct official business this morning. So I am going to officially close down the Indiana Commission on Aging meeting as an official meeting. And we'll go to information only for updates because we have people on the commission who cannot communicate with us. And we can't have an official meeting with that going on. So, okay. Well, so we will not be approving minutes. We're not going to be doing elections. When Erin does her update for us today, I want her to talk a little bit about, I want her to talk about who has been reappointed to the commission, because some of us received notifications last evening that we had been reappointed. Some people have ongoing terms. So we will clarify that. So, and the number of vacancies, and I'm really concerned about the vacancies. We have a lot of business to conduct in an advisory role here with the Bureau of Better Aging. So I really am going to be asking people to recruit hard for that. So, and we'll nudge as we can the governor's office to get this, these appointments made, because there's 1 in 5 Hoosiers will be 65 and over very shortly. That's a lot of population in this state. And as far as I'm concerned, this commission, we're not one of those very well-known, highly financed commissions. We don't cost that much, but we've got 20% of the state to be concerned about, because the statute reads that we are to study the state of aging in Indiana and the older people in Indiana. That's 20% of the population. We need to be active. We need to have a voice. We need to reach across the state. That's why I put advisory committees in place. As soon as we figure out more about where we are with who's on the commission, we know who's appointed and who's been reappointed at this point. We will take a look at our advisory committee, see if we need to rework some of that. And we want to work closely with the Bureau of Better Aging and the AAAs, and be sure that we're moving in directions that we need to be moving in and getting voices heard that need to be heard. With all that being said, without a official meeting, let's go ahead. So we can't do elections, we can't do approval of minutes, but let's get our updates from our folks at the state and see where we're going here. So I think next we're going to hear about pathways from the Office of Medicaid Policy and Plan.
Good morning. Happy New Year. Okay. Can you go to the next slide, Rebecca? Thank you. So I just have a few topics here. When I talk about how the state has moved to a fully integrated duals enrollment designation with CMS, pathways waiver waitlist, just some updates around that, and talk about some of the MCE performance. Next slide. So effective January 1, 2026, we moved as a state for individuals 60 and older to a fully integrated duals enrollment designation. And that aligns Medicare, Medicaid, and LTSS under one accountable entity. The point of this is it should reduce fragmentation between Medicare and Medicaid, because you have one payer now who has the DSNP, and then they also have the Medicaid, so they should be looking at these things together. And the hope is that we will see improved outcomes with individuals with complex needs, and we can really strengthen the accountability for quality, access, and cost. So what does this mean? Next slide, Rebecca. What does this mean for members? And that's really small, so I apologize. But the benefits for members is now they have one plan, they'll have one ID card, and they'll have one care team. So as you know, a DSNP care manager is assigned to on the DSNP side. And today, they may have a care coordinator on the Medicaid side. Now it's bringing those two things together so that there's only one care coordinator or care manager within that payer organization. And then that member only has one care manager that they need to talk to. It also means that there will be a single integrated care plan. So we went through and figured out, what assessments do we do for Medicaid? How does that tie into the health risk assessment that has to be done for Medicare Advantage? And to reduce duplication, we went in and reassigned who was the responsible entity to do the different assessments. We also did a look at the overall provider network between Medicaid and the DSNP payers for the Medicare side, and we had 80% overlap of Medicaid members also in the networks with the DSNP payers that also do Medicare. And that was what we were striving for this first year. We hope to have that continually go up. And we'll review it and track it or put in requirements into our state Medicaid agency contract that we do with the DSNP payers. The benefits for providers. So it should outline a clear accountability for care coordination. It shouldn't be up in the air. Oh, you need to call your Medicaid care coordinator, or you need to call your Medicare care coordinator. It's all in one place. It should reduce administrative burden because part of this rollout means there's only that the payer entity has to operate as one. So there's only one place you submit a claim. You don't submit one to Medicaid and one to Medicare. It's just one place to submit the claim, and then it gets routed on the back end to be paid either by Medicare or by Medicaid. That's the single payer, becomes a single payer then for those Medicaid and Medicare services. The benefits to the state is it helps strengthen oversight. As you know, Medicare has some pretty, standard quality metrics that they expect of their Medicare Advantage plans. So now we're going to use that to our advantage to help us as an additional piece of oversight monitor our MCEs that are doing DSNP. It is less of the duplication of services and cost shifting that is done today. And it aligns with the CMS integrated practices. So, what the state is really hoping to get out of this is having that one payer for both of those different products or those different benefits. With having those MCEs and then the Medicare Advantage folks looking at these claims, looking at these PAs, ensuring that it's not a duplication of services. I mean, I think what we're looking for is some efficiency eventually that we should see across the board. We should see less duplication. And the fingers crossed, it should be a better process for all providers since they only submit now to their claims to one place. Next slide. So the implementation focus is that we had to create a really strong Medicaid agency contract. And so we start working on that. We start working on that in February because that has to be complete and signed and sent to CMS by July. So we have started the process of looking at what we want in our SMAC. The CMS gives states a lot of leeway on what we can ask the Medicare Advantage D-SNP companies to do. And we also took a really deep dive this past year to align the 2026 SMAC with the Pathways for Aging scope of work. We found some discrepancies where in the SMAC, we said that they do it this way, but in the Medicaid side, we were saying, oh no, wait, do it this way. So we tried to eliminate that. And I'm sure we're going to find more when we do the deep dive starting next month. They also, CMS also approved for us to add a state, they gave us authority to do default as a state to do default enrollment. So that means now that D-SNP is going to drive your Medicaid enrollment. So wherever you enroll with it as a D-SNP, so if it's Humana, then you automatically are enrolled in Humana Medicaid. So those two pieces have to go together if you're in a D-SNP. Now you could still be Medicare fee-for-service, and then you can pick whatever MCE you want because fee-for-service is not managed. But if you're with a D-SNP, your Medicaid will always align with that D-SNP. We did priority alignment. I guess I forgot to finish the date in there. We did priority alignment on December 1st and January 1st. So priority alignment was where we looked at everybody today who was like with a United, but with an Anthem for Medicaid. So D-SNP was United, Anthem was Medicaid. And we forced the alignment then in December, unless open enrollment, they picked a different D-SNP, and then that shifted then when the alignment. So that's why we have December 1st, and then we also have January 1st. So now anybody who is with the D-SNPs, it is one payer entity, unless they go, like I said, unless they go back out to Medicare fee-for-service, which then they can choose whatever Medicaid plan they want. We worked out, because this was a big shift. There was about 4,000, there's about 6,000, I think, people who actually we had to align. And so we were really, cognizant that we needed to figure out continuity of care. A lot of those folks were on waivers. How, if their Medicaid is changing to follow the D-SNP, is there going to be impact to those waivers? So we spent probably from September until November, identifying those members, re-identifying those members, making sure that the MCEs had those members that would be leaving or had those members that would be transitioning in so that they could get those plans prior to them coming in from the priority alignment December 1st and January 1st. And then before we launched the FIDE, we did a readiness. Again, we don't have necessarily authority to sanction or audit the Medicare Advantage plan, but we do have the authority over Medicaid. And because this is one plan, and we expect the Medicare to be working with the Medicaid, we did a readiness to ensure that these things that have to be integrated are really integrated. So the network, the grievance and appeals process, the claim submission, member services, all of that has to be one one-stop shop. You can't have two different departments, a Medicare department and a Medicaid department doing those things because those pieces are required to be integrated. I already talked about the D-SNP. So we just got out of the annual enrollment period. It ended on December 7th, and now we're in the open enrollment period, and that goes between now and March 31st. So folks can switch their D-SNP during that time or go back out to they can always go back out to Medicare fee-for-service. That there is no special enrollment period that has to happen for that. Next slide. No. Yeah, it's a choice. It's a choice.
I have a question about people that need hospice.
Mhm.
That's a mismatch, I think, between federal and state on this, because this in hospice, if they choose to go on hospice, don't they have to go on original Medicare?
Mm. No.
Really?
Mm-mm. No, they stay in the plan that they've picked.
On hospice?
Mhm.
There was something when we first transitioned, I vaguely remember this about hospice, you could elect not to participate.
So if I'm 59 and I'm in hospice today and I'm about to age into pathways, I can opt out because I'm already engaged in hospice and we don't want to have any kind of, we don't want to have any kind of hiccups with the services in those scenarios. So they can actually, they can opt out of going into pathways and stay into the fee for service Medicaid. But that's the only, and then obviously we have our exclusion groups like um, Alaskan Indians, Native Americans, and so forth.
But Medicare Advantage will pay for hospice
Mhm.
under a decent.
Yeah.
Okay, well then maybe that was a while back, but it's changed. Okay. And one other question. Uh, as this transition was made, where are we with family caregiver assessments?
Oh, I have that coming up. So we'll talk about that in a second.
Okay,
So I was going to quickly just touch on the waiting list. Currently Pathways has 39,842 slots. As of December, there were 10,405 individuals on the Pathways waiting list. And we have sent out 5,096 invitations between July 1 and December 31st. Next slide. This, again, is very small, so I apologize, but this is just a snapshot of the monthly activities. So there's a summary of prior fiscal year, which ended June 30th, 2025. And then July 2025 starts the new fiscal year. So that shows to date through December how many invitations have been sent to people on the wait list.
Do you, Holly, the last couple of months, it's been 300. Do you anticipate that being a number going forward? Do we have any concerns about the cessation of invites based on slots between now and the end of the fiscal year?
So I think we're constantly reassessing slots. And I will tell you, like, we get notified of date of death a lot, like several months after the fact. So, we were finding where, oh, wait, this person died way before, June 30th. So that should be an open slot. So we're doing a lot of work to clean up slots to make sure that they're being used appropriately and that we're identifying those people a little quicker. Um, I think that the 300 is probably going to be the number. I think where we're concerned is that we can't overshoot that 39,000 because that's what CMS has approved. And so it really depends. I would say probably starting in January, February, we're going to be able to see how many people have accepted. So we now have a 180-day look back. So any invitation we sent out, so we sent out 1,300 invitations in July. So in January, any invitation that was not responded to, we rescind and then recycle it. So this will be the first, January will be the first look back month. So I think 300 is the norm probably for just traditional slots as they are today. And then I think we're going to see then a big chunk come back around of invitations that weren't responded to. And that would start, not this month, it'll probably start in February. Next slide. These are the priority categories. I just wanted to make sure everyone was aware that we have a certain number of slots that we reserve. So out of that 39,000, we pull 5,301 138 slots out of the total number so that we can ensure that we have enough slots for these priority categories. So assisted living, if someone is in assisted living and they're doing, a spend down to get on Medicaid, they can put in an application to use a priority slot once they get onto Medicaid. Money follows the person. That restarted recently. And so anybody coming off of Money Follows the Person after 365 days has an automatic slot reserved for them. And then we also try to predict how many people will be transitioning in from health and wellness aging in. So that number gets pulled out. We've got the nursing facility reentry. And so that's usually someone who is long-term care that has decided they'd like to go use home and community-based services, or that's someone that's been in the nursing facility for more than 90 days. And maybe they've, because they were in the facility, they've now lost where they live and they have to restart that whole process again. So every month, then anybody who's on the wait list that falls in one of these categories, they bubble to the top automatically. We give out the reserve capacity. And then whatever's left from that month, then we send out invitations for.
How do you know those people?
We have priority categories. So when they go on the wait list, they have to tell us and so Maximus or the MCE does the level of care. If the level of care is approved, there's a question on the level of care that says, what program are you in? Where are you currently at? And then what program do you think you are going to go into? And so then we assign the priority category off of that.
So Maximus with the MC.
Yeah, it's one of the questions on the inner REI tool.
Okay.
So
if there remains a slot when they apply, as long as there's
yeah.
slots, those are actually reserved.
Yeah.
The others are the priority, like if they're transitioning from a hospital.
Okay. Who may be on the waiting list.
They could be on the wait list. Yeah.
Those may be on the waiting.
Yep.
okay, that kind of comes to my question. So I chatted with a social worker in the emergency department in a critical access hospital 2 weeks ago. And I'm trying to figure out where these people would end up in our system. And the issue was, well, somebody may have been in hospital over 3 days. They've been there admitted. Had, let's just say, a stroke, paralyzed on one side. Hard to get people rehab. Doesn't last too long anymore. Cannot get anybody into Medicaid pending nursing home anymore. Struggling with that. Let's say they're in. So if they aren't going to be in nursing home long term, they're just going to be there a short period of time. They don't end up prioritized on anything.
But we don't have an acuity. I think what
No
you're,
acuity.
yeah, like a wait list that's based off acuity need, and urgency, I guess.
Clarify.
Yeah, that's not how the wait list is set up right now. It really is, when you go on the, outside of having to reserve the priority categories, it's, really wherever your name is, when you came into the wait list, you're just going to be next up on the list when it gets to you.
I'm just clarifying,
Yep.
not criticizing anybody. I'm just trying to figure out as the general public, what on earth do these people do?
Now they have access to this. They have access to the home health, like home health services. So they should be utilizing like home health aid and skilled nursing.
But if they can't get on Medicaid, and they don't have money.
Well, yeah. So the Medicare, I mean, yeah, the Medicare cut would cover per episode, yeah,
But
yeah.
that's also
Yeah.
be an issue. I'm just saying, we have some folks out
Or
here that,
if they are on the waiting list and they are in a hospital
Mhm.
or a nursing facility short term,
there's my.
and they are discharging that month when we release from the waiting list, not these reserved, when we release from the waiting list, if there are slots available, right, it's always if.
Yep.
Those people do get priority. They elevate up off the waiting list. That is distinct from reserve
Okay,
capacity.
that's all I'm clarifying here.
So that is a waiting list process.
Okay.
But there has to be a slot.
But there
Yeah,
has to be,
yeah.
we have.
I mean, there's still some, there could be a delay, I don't.
Yeah, he bit my head off and said, well, I can't get these people anything. And I thought, "Well, just ask questions down here. I know but we do have these people.
Yeah, and that's why part of that 180-day invitation before it's before we resend the invitation, part of that is because we know people need the waiver for the special income limit. And so they have that 180 days to also get that application submitted, get the process, go through the process. And then once the Medicaid's in place, then that's when we can start that waiver.
Okay. My response to him was, but this was what voters had chosen to do. I didn't know what else to say because that's the truth. But,
Hey, Holly, can you go back to that previous slide, the
Yes.
snapshot of
Yeah.
the dashboard?
Yeah.
And I apologize. I don't know if this is helpful, but you see that breakdown each month and it'll say discharge from hospital, transition from choice. Sorry, I'm reading it from.
Yeah, I know it's right.
So if this helps make sense, and I don't know that it will. Every month when we say we have X slots to release, right? Those are the folks that are coming off the waiting list, and that's the breakdown of the folks that they became priority off the waiting list that month. So they could have been, say, just in order of entry, 3 months being on the wait list, but they're discharging from a hospital, transitioning, whatever. They elevate off of. Yeah, I'm just telling the crew. But the reserve capacity slots aren't counted here. That's why there's a separate grid for it. And those are the ones that there are special slots held for them.
So there are 302 invitations to someone who doesn't have a priority need on the waiting list. And in the month of, just for the month of December, it's 129 that had the special slots based
Yeah,
on.
whatever it says that breakdown.
Yeah.
Of the total.
Yes. I can read that, but I can't read this computer.
Any other questions?
thank you.
Yep.
That's helpful.
Can we go to the next slide, Rebecca? Oh, the next one after that one. Okay, MCE performance. So I just wanted to kind of review some of the monitoring entities or requirements that are in place. And because we now have a full measurement year for 2025, we're going to be able to validate and see where the MCEs are performing well or not performing well when it comes to member care. So we have the NCQA measurement year that will be now. That includes the CAP surveys, which are the consumer assessment it's like, it is definitely the survey on member experience. So those start now. The MCEs and the Medicare Advantage plans use third-party companies, third-party surveyors to do these surveys. And I believe it runs through April. So they'll start making calls, I think February 1st, and then it goes through April. And so there's one of the consumer voices we get is through the CAHPS survey. The nice thing about NCQA is that they actually validate the accuracy. They audit the file, all the files. Sometimes that makes our jobs a little bit easier because we can use what they have validated as far as metrics for health. So, did we do well with adult wellness, checks, vaccinations, all of those different metrics that NCQA requires. And then that gets reported around June, May or June, and then the results get published in September. So today you could go out and pull up Indiana, and for Medicaid, Anthem, CareSource, and MHS all have a 3.5 rating, and United has a 4 rating for Medicaid. And then you can even break it down to see where they scored for each of the metrics that are assigned. We also are in the process of doing the National Core Indicator Project. So this is specific to HCBS services, but Indiana University is calling different individuals that are receiving HCBS services and going through kind of the National Core Indicator survey list. And that should conclude in June of 2026. So they've been doing it pretty much since this past fall. And then we will conclude on June 2026. And then we have the external quality review. And that is a CMS requirement as well. And they have required protocols that the Medicare Advantage have to follow and the Medicaid have to follow. That is done by an external company that the state contracts, and they have, they do secret shopper calls. They actually call members assigned, pull random lists, and they call members. And then that report is usually, they usually start this, I would say probably in April every year. And then they just finished for measurement year 2024. They just finished their review, and we should get the final report, which has to be published somewhere around February or March of this year. Next slide. So just some things to note. We did transition over 600 individuals from nursing facility placement to pathways. MCEs did, and that's from 7/1/2024 through October 31st. So that's more of a year and a half kind of look back. But so again, because we have different how we code folks in our wait list system, and then once they accept the waiver and start service, then we mark it in the system. And so we are able to track by those priority codes who received a waiver and when did they start. And so that's where, so it was 616. Just so I wanted to just make it a little over 600 because I'm sure there's some on there that there's more on there that have come on since I've done this slide. And then assessments. So January 1, 2025 through November 30th, we will be getting December data today. The MCEs have to submit it today, but the MCEs have completed over 10,000 caregiver assessments, and they have completed over 50,000 comprehensive health assessments face-to-face, and they've done over 100,000 in total. So we've got some of the population, HCBS population, where the comprehensive health assessment is to be done face to face, but then we have the non HCBS or non-duals. I'm sorry, non-HCBS or duals that that would fall into the other 50,000, and those can be done over the phone. Areas though that still need a lot of work is claims. They are still not meeting set metrics around claims. It definitely has gotten better, but it's not where it needs to be. So we continue to manage and monitor the MCE claims issues. Prior authorization, I'm not sure if you're aware, but last year there was a bill that changed prior authorization turnaround time from 5 business days to 48 hours. MCEs are having a hard time with meeting that 48-hour turnaround time. And then the MCEs did not meet the set metrics for their payout for pay for performance. So we call that P4O. And so from 7/1 to 6/30 of 7/1/2024 to 6/30/2025, we hold back, an estimated 2% of the total years what we anticipate to be pay the MCEs for that state fiscal year. And then, so we put that aside, and then they can earn it back by meeting certain metrics. And they only earned back 30% of that overall 2%. They met one of the metrics 100%, and then and that metric was only worth 30% of the overall withhold, and they did not meet the other two metrics. And the other two metrics were really based on HEDIS and NCQA requirements, because that we feel like that data is reliable. So I think one was grievances and appeals, and the other one was timely assessments.
So happy to see the number of caregiver assessments. Is there anything that the state of the MCEs are doing with that data? It's being collected as part of MCE.
Yeah, it should. I mean, they should be working that in if it's a service plan or if it's a care plan. Any action steps that need to be taken as a result of the caregiver assessments.
Okay.
I don't have examples of those, but we can get some, like what is the decision tree based off the assessment.
Okay, that's built into the members.
Yeah.
Yeah, we really lagged in the state for years on support for family
Yeah.
caregivers. And I've been hearing in the last 6 months that MCEs are not utilizing adult day services for respite for caregivers. That's where my question's coming from.
I have been monitoring the adult day utilization monthly, and kind of and then sending out questions around where are we at with what if this number is lower. So I've seen the numbers for adult day utilization slowly climbing up. Area that I've been watching is the caregiver coaching. That has had low utilization, and I've been really on the MCEs, and that, that has not had a upward trajectory, but to be fair, I only started sending them questions regarding it in October. So I'm hoping that, we'll see more utilization of those services as well. Respite, I'll have to look, because I haven't really looked at the respite utilization. So I'm going to have to go back and look at that and see what it looks like.
Yeah, it just seems like a rather conservative approach to keeping people at home instead of burning out the
Yeah.
caregiver and
Yeah,
getting them institutionalized.
Right,
So I'm
right.
kind of following that in the state to see what we're doing here.
yeah.
The guide model uses respite care,
hmm
but I don't know what we're doing here with the MCU.
They are following the guide model as well. That was part of Dr. Council worked with the MCEs on some of that. But yeah, let me take a look at that data because I haven't really looked at the rest, but I've been really watching the caregiver coaching and the adult day pretty closely. And that's my last slide. So any other questions or comments? Oh, yeah.
Client changes their D-SNP, will the Medicaid all change? Should their insurance help them to update their pathways?
Yeah, so what happened, I talked about earlier that CMS granted the state the authority to do default enrollment. So if someone chooses a new D-SNP during this open enrollment period, the Medicaid automatically follows it. So we get the Medicare file from the Medicare Advantage file from the payer. We load that, and then Gainwell then gets an alert that then they have to, or the enrollment broker gets an alert that they have to switch from Medicare or from one MCE to wherever the D-SNP payer is. Yeah, if I had a little bit more detail about what outreach and lack of response, I think that would help me go back to the MCEs on. Okay.
I just have a positive experience.
Uh-huh.
I wanted to share. So my aunt, is disabled. She's 67. Just moved her to Indianapolis in March of this year.
Uh-huh.
She was enrolled in Pathways, the program. We just transitioned her over to the same health plan provider. She had traditional Medicare. And so we've aligned her Medicaid and her Medicare. And it's been really great so far. And I mean,
Yeah.
the health plan provider is providing her with a monthly gift card
Mhm.
to help with utilities and.
Yeah, I mean, I think that some of the supplemental benefits that the different Medicare Advantage plans offer, I mean, those, you can't beat that. Just, I don't know if I've shared this before, but my brother's on the family support waiver, and I signed him up with Humana for the 2025 year, and he got the same card reloadable every month. And they load it, I think, with $200, and so it's one of those things that supplemental benefit has prevented me and my other siblings from having to give him money to be able to afford his rent and his utilities, because he's now got this card that he can spend on food. So
She called yesterday on her own. She generally participates, but she called Anthem. Oh, sorry. Didn't mean to say the plan. She called the plan yesterday and arranged to have all of her medications moved over to delivery, which relieves me from having, to take her to Kroger to get them.
Yeah.
And so far, it's been really positive.
Yeah.
Well, I think one of the things I'm seeing is that people don't understand,
They don't.
and that's causing frustration all over the place. They still want to be on the old model. They still want to take somebody to the nursing home and just put them in Medicaid planning. And I don't know how we're going to get the message out to people that we're shifting gears here, but they just don't understand.
I went through a broker, to be really honest. I've been doing this a really long. I went through a broker to help me navigate this.
Yeah, I mean, that's true. I mean, that's why I visited an adult day. I visited assisted living. I visited a AAA. I visited a critical access hospital and a nursing home. One day before Christmas.
Oh, wow.
Nobody's happy, including people in the community who've been yelling at me because they don't understand what's going on. So, I mean, part of it is there's a massive education initiative needed. I don't know whose responsibility it is. And I've been doing a lot of work to try to nudge more education in local communities, because we got to do things differently. But it's like voters kind of vote one way, and I'm not criticizing anybody, we voted, we got what we had. But then they don't understand why
Mhm.
something isn't there that they want, even though
Yeah.
they voted for something else. And so we really, I know we're supposedly not advertising. We can't advertise it. How are we?
No, but we can still do outreach and education. I mean, that money is still there, and it's still an expectation of the MCEs to be doing outreach and education on the benefits.
Well, thank you.
Yep.
And we really do want to keep connected with OMP.
Yeah.
So please come and talk with us because this.
Yeah, I talked to Aaron and, said, maybe the next meeting, like I'll skip and then come back in May. I can't remember. But anyway, I think that if we can come in 3 or 4 times a year to give an update. Unfortunately, at the end of last year, we had a big shift in something. So we had some shifting priorities but now, we should be back on track now. So.
Okay, well, we appreciate it and need to talk with you because this is a population
Yeah,
we're really asked by statute to keep an eye on.
right.
So that's how we can best do it. So thank you very much.
You're welcome.
Oh, Erin, give us an update on the Bureau of Better Aging, what we're doing here with the commission and so forth right now.
Yes. So we are continuing to work towards the merger of the Division of Aging and DDRS. There's legislation pending now. I think that it says anything will officially, if it's passed, go into effect July 1. We, as you know, have operationally merged as of last summer. We are in the process of recruiting for a number of vacancies, including members of our leadership team. We have a new ADRC manager who is here today and has been helping with technology, Ben Simpson. Thank you for that. He is working with Rebecca McLaren, who has been promoted to our HCBS director. So in future meetings, we hopefully will be introducing some new staff as we grow our team. And we've really been trying to focus on restructuring and better supporting the work that we currently do, but also to be able to better position ourselves to help support aging Hoosiers across the board.
Can you say a little bit more about Rebecca's position? So did you say Director of HCBS Services?
Mm-hmm.
And so would that be, what services would those be?
So it's a lot of actually the responsibilities that I had with the Older Americans Act. So our non-Medicaid choice, Older Americans Act services, our dementia care services will be under her.
Perfect.
So related to that, we are continuing to work on the draft of our 2027 23rd State Plan on Aging. We will be going out for public comment probably later this winter, early this spring. I know we talked about it a little bit at our November meeting, so we'll be sharing updates as that draft moves forward. I'm sure Hannah will provide an update on the rollout of the Yellow Dot program, but I did want to recognize I4A and AARP for all of their efforts in helping to get that off the ground. The support they provided, the resources they provided. This was an unfunded mandate and they really made it happen. So thank you for that. We will be updating our website soon to house some information on the program. But I just, again, thank you. This month, as of January 1st, we rolled out an increase of $15 per day for the per diem rate for our residential care assistance program, or RCAP. RCAP is a state-funded program that supports low-income Medicaid eligible individuals who reside in licensed residential care facilities or county homes. These are individuals who are not eligible for a Medicaid waiver, but receive assistance with room and board and medication administration. There's about a little over 200 residents in the program. About 70 to 75% of them have experienced some sort of mental health disorder, ranging from bipolar to extreme depression. So this program really, I think, fills a gap. And so we were glad to be able to roll out the first increase that we've had actually in many years. So happy about that. The big thing that I wanted to talk about today is last legislative session, House Enrolled Act 1391 was passed, and this was often referred to as the choice bill as it updated language in the choice statute, but there's also language in 1391 that updated the code related to the responsibilities of the Office of the FSSA Secretary, and there was language included that spoke to, in collaboration with the AAAs, evaluating and preparing a report with recommendations for realigning and consolidating the planning and service areas for the AAAs. And Rebecca, you can go to the next slide. So as you know, we currently have 16 planning and service areas. These were designated under the Older Americans Act in the mid-1970s. And as far as I'm aware, we really haven't done any kind of in-depth evaluation of the planning and service area structure, maybe ever. You know, as we regularly talk about in these meetings, populations has changed. The system of long-term services and supports is evolving and is continuing to evolve. We distribute funds to these planning and service areas using a population-based funding formula that is approved by the Federal Administration for Community Living. And there's really a lack of kind of alignment in the resources that are allocated to the different areas. We have a number of AAAs that receive around 2% of the total funding available. And then our largest is it's over a quarter of the funding. And with the requirements of our non-Medicaid home and community-based services and the responsibilities of an area agency on aging, they're all held to the same requirements, expectations as far as administration of program and the implementation of programs and services. So in looking at the distribution of the counties and the planning and service areas, we're really looking at this as an opportunity for looking for efficiencies, really increased sustainability, and more opportunities for collaboration and coordination. Again, as we undertake this evaluation, we will do so in conjunction with the area agencies, and the code actually specifically calls out your involvement as well as the choice board's involvement of with this process. We don't obviously at this point have any idea what is going to come from this process, what the recommendations are going to be. I anticipate that there will be some kind of consolidation from 16 down to a smaller number, whether it's 5, 7, 8, I don't know at this point, but I anticipate that there will be a realignment and a consolidation to try to move towards some more balance throughout the state. So I'm going to share a tentative timeline for this process, and it's small, and I'll send out the slides afterwards. There are federal processes that we need to follow, as well as state processes that we need to follow. And I kind of have been trying to look at it as there's two big steps. First, we have to determine what the planning and service area structure is going to look like, what the map is going to look like. So there's one process for that. And then there's a process that we have to go through to designate either a public or private nonprofit entity to serve as the AAA for each planning and service area. So first there's the PSA process, and then there is the AAA designation process, which could potentially involve a de-designation process because we currently have 16 PSAs. So just to, again, this is high level, and there's all kinds of lines and overlap. So I really, in working on this, tried to make it as simplistic as possible, but we anticipate over calendar year 2026 really working through the recommendations for the PSA planning and service area design, as well as an updated population-based funding formula for allocating funds to each of the planning and service areas. The interstate funding formula has a lot to consider and go into it. So while this is an aggressive timeline, I'm hoping we at least built in some adequate time, just because there's a lot with these processes. So we'll come to recommendations, and then we will engage in a public comment period on a draft amendment to our state plan on aging, which has to approve any changes we make to the funding formula. And also there is Indiana code that says we have to hold a public hearing, and it has to be in person in the county, in each county that is affected by potential changes in the sorry, thank you for your face. In each county that's affected. So potentially completely redesigning the map would require up to 92 in-person public hearings in a time frame. The Indiana code also says that before we can implement any changes, there's a 1-year waiting period from the date of the hearing. So looking at it that way, we have a 1-year waiting period from whatever the date of the last of the potentially 92 hearings that we hold before anything can go into effect. I guess, part of the process that's working in our favor is once we have a structure and we've submitted our amendment to the Administration for Community Living, there's the process to designate the AAAs, which will go through and process some kind of competitive process with IDOA. And that process can generally take 12 to 18 months. So we will go through a procurement process to designate new public or private nonprofits to serve as the designated AAAs for whatever the map looks like. In that process, at some point, as we gear up to make the transition, there will be a de-designation process for existing AAAs, potentially, depending on what the map looks like. And then if all goes according to timeline, we would be looking at transitioning and go live with the new map in October of 2028, which is the start of federal fiscal year 29. It's an aggressive timeline with a lot of layers, and under each of these, there are really more requirements and nuances to consider. But again, I really tried to keep it as high level as possible, just as we're really starting to talk about beginning the process for working on the study to come up with recommendations for realigning and consolidating. I know that was a lot, and are there any questions?
All part of population aging and urbanization that's happening globally, and a time to educate people at the local level. And we have some parts of our state that will be struggling to have services, and yet we'll have a lot of older people there. So this is very important and also an opportunity for some public education.
Mhm. And I do want to add that the Older Americans Act has very specific requirements for the responsibilities of an area agency on aging, and a local connection is wrapped into that. So as we're going through this process, I really want to make sure that we don't lose sight of that, and probably that will be, you know, highlighted more in whatever the procurement process, whether it's a request for proposal, a request for funds, whatever that looks like. I think that's really where we'll try to make sure we're incorporating that.
So in this process, and you may not be able to answer this question, but like when a AAA or multiple AAAs are de-designated, they receive no more state or federal funding directly
Through our grants.
through your grants,
Mhm.
right? What happens to, I guess I'm assuming whichever AAA is not de-designated, but now responsible for a region is responsible for Aging and Disability Resource Center and ensuring coverage across all counties in the area in which they're responsible.
And we have built in, and obviously there's still a lot of details to flush out, but anticipate there will be some kind of transition period to make sure any transitions can occur as seamlessly as possible.
Yeah. The difficulty gets to be this, the service providers in these rural areas shrink, but the older people don't necessarily move. That's
Service
that's,
providers being who?
well, I mean, I'm thinking what I saw in South Korea when I went over there and did my study several years ago. The rural areas mostly were older people in them. There wasn't employment. People had lived there all their lives. The service providers were in more of the urban areas. And
I
it's
think we
just,
have that challenge today. I mean,
yeah, it's growing is what I'm saying. That's urbanization and population aging. And yet people think there's something there for them, even though, and I'll just say it, I mean, people don't like to pay taxes, but a lot of the services were tax supported kinds of services like Medicaid, and they don't understand what's going on. They kind of don't want to pay taxes. I'm not criticizing anyone. I'm just saying when you don't pay taxes and you're depending on tax supported programs, they won't be there. And that's what, you know, our education, we kind of going to have to work with folks to understand the way we do things. We could do it differently. The way we're doing things right now, as we go through this process, we're going to have that. We're going to have a lot of people with needs in areas that don't have service providers and don't understand why they don't have things, even though they don't understand the funding. That's the main problem we have right now. So we've got, I hope we do. I'm pleading for a lot of education in some way for these for folks to try to understand. That's what I'm seeing across the state when I go talk with people, providers and the general public. The providers know there's not funding there. The general public doesn't understand what's going on. Then they yell at the providers because they can't get what they want. They don't understand how it's funded. So we've got a bit of a problem to kind of help people understand what's going on. And so what I see with collapsing some of this administrative overhead for AAAs, and I think that's what I'd call it, we still have the people sitting out there with the needs. And we're getting further away from the local areas. So, people don't understand that. They think, well, it ought to be here for me, like rural hospitals closing. It's going to be more and more of a problem if we keep going as we are going. So I don't know. We just have to do a lot of education, I think. Good people just don't understand how things are funded. They think it's there and it's not. So I know there's a lot of efforts around to try to help people understand, but they just really aren't getting it. And then they're frustrated and very upset, but they don't understand. So as we collapse this, it's just that it's these larger movements that are happening, population aging and urbanization. It's hitting everything, schools, everything. But we know we'll have people out there with needs. Now, what are we going to do? How are we going to provide services? Important to think about as we move toward collapsing these area agencies on aging in order to save administrative costs. I can't think of any other reason we're doing it than that, but we still have the people. They don't move. There's, what we saw in some of these countries is that eventually they have to go with their kids in the more urban areas or not. That's the problem.
I would hope as part of this whole process and this whole transition that there's still a place for those individuals who are with a certain AAA, right, in a rural county, so that there is still access, just because they're changing, the change of the oversight of that region changes. I would hope that the local access to resources and information doesn't change in directing people.
Well, a lot of people don't know how to even begin to access, though. They look to their healthcare provider, and primary care is not necessarily connected with the resources. How can I say this nicely? Another way, I'm just kind of saying the truth. They kind of say, I don't know who to refer to. So the area agencies have had a very important role. Nothing's perfect, but I mean, as we shrink them, we get less connected locally. So we'll have to just be alert to what we're doing in our systems, because we have a very disjointed health and social service system to try to get people connected. I'm just raising issues, asking for, a lot of education, because people don't understand. They just don't understand.
Yeah.
So more to come on this, future meetings.
Thank you. I
Mhm.
mean, that was helpful to hear where we're going with this, what the plan is. I hope they're not
Tentative plan.
retired by the time this gets done. It sounds like a lot of work. And it's kind of there's good reason it's a lot of work for the things we've just talked about, but that helps to know where this is.
So I will be sharing with the Choice Board this afternoon as well. And the plan is to talk about it at the upcoming quarterly financial review that FSSA is holding at the end of this month. And I think the next slide is the save the date for that. So it is January 30th here in the auditorium, and then it will also be streamed. I think at this time, DDARS is scheduled for 1:30 in the afternoon. The 30th is a Friday. In past quarterly financial review, there has been some shifting as the date nears. So I don't know if anything is going to shift, but currently we are at 130. So, all right. Thank you.
Thanks.
Okay, I was drifting into thought and forgot I was running the meeting. Okay,
Were you going to ask Aaron to discuss the board members?
Oh,
yeah,
Sorry.
thank you.
yes, we need to review that, yeah. Thank you.
So there are supposed to be current 16 members on the Commission on Aging.
16,
16. We currently have 11 of 16 slots filled. We are in need of a direct provider or a employee of a direct provider, like a direct service worker, through services provided through the BBA. We have 2 at-large vacancies. And we are missing a service recipient or caregiver of a service recipient of DA programs. And then we also are in need of an individual representing areas 10 through 16. So somebody from the southern part of the state. I have had conversations with Amber and Hannah, and they're also helping.
yeah, we really need to get on this and try to get voices here at the table. We would appreciate any help anybody can give us to try to get this. So it takes a while through the governor's office, even if after we get them nominated, but we really need to get voices at the table, especially with a lot of change going on right now. So would appreciate any of this. I really hope we get a care receiver, caregiver on here. I'm always opening my mouth trying to talk from the consumer side as well as the other, but we need people on here. I'm hoping this just is a very, very active commission during all that we're doing. And as I said, I'm hoping that we can get together the chairs of the advisory committees and the current executive committee, and we'll have to come up with the nominations for the officers for the commission. Now that we have at least more people, we kind of know who got reappointed because we had that sitting there, and see what we can do with the advisory committees, because I'm hoping through the advisory committees we can get more voices to the table here. We'll take a look at those and see if we need to shift and rename some things and bring in more people. But this is important. That's why that's just me. I got the microphone, so really trying to get input across the state, because this is really, really important. I'm going to say it again. We cannot cut our way out of the issues because population aging is happening. We have oceans of people like me out there, and will for quite some time. So just cutting isn't going to do it. Rationing slots isn't going to do it. We got to come up with more things that creative and work on this. But I think educating people will help a lot. But I don't know. I don't have all of that. We need all our folks that work across the state in our many wonderful agencies and organizations to help us with this. But boy, they don't know, and they get frustrated and they scream at providers and they just don't know. But we have to make changes, but cutting isn't going to solve everything. Creating more problems. So, okay, we'll work on this. Thank you so much. Okay. As we look at our advisory committee reports, I've already said that I know we need to look at our advisory committees. From the Living Longer, Living Better collaborative, we certainly will be working with Vanessa Congard on the multi-sector plan on aging that we worked on for quite some time in this state. And I hope we move along with that. I've asked Tina McIntosh to help me chair that meeting, ask her to chair it, and I'll kind of be sitting in the background there because I'm currently chair. I don't know where we'll go from that as we move forward, but anyway, chair of the commission. So I was trying to bring some other people in. Judith, you've been on shared decision making. Do you have anything to bring up there this morning?
May not be able to speak, remember?
Oh, I'm sorry, you probably can't speak. Deb Lambert, I don't know if you were on, but I'm not sure. Probably not. Kelly, you are here, so I'm going to ask you to, do you have anything from family caregiving?
I actually don't. We are scheduled to meet next week. So I will have some updates for our next meeting.
Okay, and Dan cannot speak either from housing supports, but we'll all be meeting and seeing what we can do with these, how to align it with some other things that are going on right now. We'll update these. Dan cannot speak on the Senior Center Coalition, but Hannah's here. Great, Hannah. Let's get an update from I4A.
Yes. So as Dr. Brooks said, I am Hannah Carlock with the Indiana Association of Area Agencies on Aging. First off is the federal update. So we are looking down the barrel at another government shutdown. It seems the House has passed around 4 funding resolutions out of 6. So they're making headway, but they have to either pass a full year spending bill or another short-term funding solution before January 30th to avoid that shutdown. So no pressure. But we are currently urging congressional leaders to protect and increase the Older Americans Act funding, especially since that's how AAAs really function. As Aaron said, I'll be providing a yellow dot update. So we actually have the packets thanks to AARP. The packets include the yellow envelope, the sticker that goes on your car, as well as instructions, and then the actual emergency medical information that you then fill out, which we are encouraging folks to fill that out with pencils. So if they do need to make any updates, that's easier than pen. And each of you didn't know you were going to get a gift. You get a gift today of a yellow dot packet.
Thank you.
Thank you.
And these are now available from the Bureau.
Yeah, so you can go to a AAA location or a BMV location to pick up the packets. And the Bureau of Better Aging is working on launching their website for more information around the Yellow Dot program. And so hopefully that'll be up and functioning within the next few weeks. So by the time that we're back here, that will be live and going. We are in the midst of our legislative session here in Indiana. The governor actually gave his State of the State address last night. Some of the big initiatives are affordability for housing and utilities, which are agenda items. So House Bill 1001 is the utility bill, and it actually is the housing bill, and then the utility bill is House Bill 1002. House Bill 1003 streamlines all of our various boards and commissions. You guys are safe. There are a lot of boards and commissions that are being completely eliminated, but the Commission on Aging and the Choice Board are still actually involved as of right now. They are continuing to work on that, so can't make any promises, but you guys are still a live commission in House Bill 1003. House Bill 1029 passed out of committee this week and was actually up for review just a few minutes ago in the full House. It'll be voted on next week, but that bill is requiring the Department of Health to work with the Alzheimer's Association and other partners on Alzheimer's and dementia education. So the AAAs will be working just because we have the dementia care specialist to become partners with the implementation of that bill. Things are very, very quick and fast paced because we are looking to adjourn February 27th, so even quicker than usual. The big FSSA bill that is, as Aaron referred to, kind of aligning how is currently practiced. So instead of the Division of Aging, it's going to be the Bureau of Better aging. That is with, that language is within that bill to align how the current practice is.
What's the number of that?
Senate Bill 222.
And that's got the dementia in it as well as the other.
No, so that is like aligning FSSA with how they're
Which was
currently
the,
being practiced.
which is the dementia bill?
The dementia bill is 1029.
Thank you. House,
Yes, House Bill 1029.
thank you.
There are various fiscal matters that the mainly the Senate are wanting to address within FSSA. So Senate Bill 1 is the Senate's big priority bill, and that is really like narrowing the door for all of the safety net programs within that the state provides, like SNAP and CHIP and all of those things, for making sure that we're fully vetting Hoosiers, so illegal immigrants cannot receive those benefits if Senate Bill 1 makes it through the legislative process. And then there's just some other fiscal matter bills that and make sure that if you are on a Medicaid waiver, you cannot be spending more on your Medicaid waiver than institutional care. So either being in an institution or nursing, a nursing home. So just making sure that we are sticking with, you are waiving your right to be in an institution, and that we are aligning with paying at that same price or lesser than that price to make sure that the state is being fiscally responsible, and that is, you know, placed on us by the feds to show that they are maintaining that level of funding that's underneath that threshold of what an institution or nursing home will cost. So I believe that is Senate Bill 275. That is by Senator Mishler and Senator Garten, which are pretty much the two heads of the Senate Appropriations Committee, and that's being heard today in the Senate Appropriations Committee.
So Hannah, on that, so today the state's responsible for managing
Mhm.
those care plans, right? To ensure that there's budget neutrality. So
Mhm.
somebody could be over
Mhm.
institutional cost and be in the community, but what you're saying in a go forward is you can never be above institutional cost?
Correct. According
And
to
is that across all waivers?
that, according to this bill, will be across all waivers, all home community-based services.
That's interesting.
Yep.
Ah,
And then on Monday, we actually had our day at the State House. So we had all of our AAA leadership meeting with their legislators. We also presented our Legislator of the Year award to Senator Good. Senator Good was our Senate champion last year for House Enrolled Act 1391, which is what Erin was just referring to in her presentation. So it's great to know that we're working to build our roster of champions in the General Assembly. I know Representative Clear on the choice board, he was the author of that bill, but it's great that we had Senator Good to work alongside him. Our main communication with legislators on Monday was pretty much the statistic that Dr. Burke referred to. By 2030, 1 in 5 Hoosiers will be 65 and older. So even though legislators may be touting all the dollars we spend on services like choice or home and community-based care is a dollar not going to our students in the classroom, we are going to have more Hoosiers outside the classroom than in school, and AAAs are here to help meet the needs and partner with the state. And so we just want to continue making sure that the state realizes that we are an aging population, aging state, and we want to be that resource. Rural health grants, the One Big Beautiful Bill passed by Congress and signed into law on July 4th, included rural health grants to help with access to care. The Department of Health is putting on regional meetings this week to educate community partners about this opportunity, and AAAs have been attending those meetings to see how they can be a community partner and help with access to care, transportation, et cetera. So we are being a part of those conversations. And then going back to like the membership of the Commission on Aging and Choice Board, Amber with AARP and myself have been working together on those applicants and working together on those recommendations so we can hopefully get those submitted before the next Commission on Aging meeting, and leveraging any legislative push to the governor's office to get those approved, because that is a slow process.
is that the 270, is it 270 million the state was awarded? By getting this?
Yes.
Okay.
Well, I thought it was 1 billion. It's over 5 years.
Okay.
It was 50 billion. Yeah. Yeah.
Oh, that's it. So 270 million, and 200, whatever.
It's like 205, 206.
Okay,
Yeah,
okay.
it's over a 5-year period.
And so tell me, can you say a little bit more about what you're doing, you and Amber are doing around applications?
That's for the Commission on Aging Choice Board membership to try to get,
I thought you guys were
quorum.
doing the applications for rural.
Nope, nope.
Wow.
Yeah, there we go.
Above and beyond.
I'm really excited. Okay.
Any other questions?
Well, I just want to comment, thank you for your work. I am so happy we're working together in this state across a number of organizations that are working with older adults and their families. And I just want to say, it is so sad when we pit one population against the other. I just want to say that publicly, that's not fair. Because we want a good standard of living and quality of life across a lifespan, not pit children against older adults. That's just not nice. I don't know how else to say that, but somebody needs to say it, so I will. That's just really not nice. And it's done, it's a tactic that's been used for years, but that's really ridiculous. So, we need to be sure when we talk, it's not just one group over another, but that together we want to have strong communities. One of our problems, and you know I say this, and you've heard me say it, some of you, the 1900s, we discovered childhood, and we really developed a lot of programming around children in our communities because we had no concept of childhood in the 1800s. That came about in the 1900s. This century, I think, is the century where we have more people living longer than ever before. So we are developing our communities to include more older adults. When you get this pitting one against the other, it's ridiculous. And it needs to be called out. That's ethically just doesn't make any sense. So I know I'm preaching to the choir here, but it needs to be said. That's why I said we can't cut our way out of these things. It's how can we sit down, roll up our sleeves, and come up with some practical solutions that make life better for all ages. And I think that's what we're really kind of hoping will happen, but we get ourselves in these quagmires of ridiculous things. So thank you for all your work. It's not easy to go and fight for money. But, but yet people want the services, they want things, but it's, well, how do we get there? Well, you can't expect somebody else to pay for what you need. We all have to get in there together. So anyway, thank you very much.
Thank you.
Appreciate it. Is there anything else to be shared in our informational meeting today? I can't even close the meeting because it's been not an official meeting, but thank you everyone, for those of you who stayed online, for those of you here. Hopefully we'll have our glitches taken care of in our next meeting in March. And I think are surviving, or at least at this point, surviving the cuts to commissions. So we're here and working with our partners in the choice board because it all works together. And want to continue to have that go on. Thank you for getting OMPP here. We want them here too because it's all part of what we do. And some of you know, it doesn't make any sense to me that we have the Indiana Department of Health over here, there, and FSSA over here, and some states don't have that. It just puts more of makes us work a little harder to work together, but the social determinants of health are very, very important to our well-being. So anyway, thank you, everyone. Thank you, AAAs. Thank you, the State Unit on Aging. We're all connected here and are looking to better the well-being of all ages in Indiana. All right, stay warm, everybody. See you in March.
Receipt.